Welcome back to the Neurologic Wellness Podcast. I'm Dr. David Traster, and I'm here with my good friend, Dr. Jonathan Chung. Thank you for being here.
Hey, Dr. Traster, good to be here.
So, Dr. Jonathan Chung is actually a specialist in many things, but I think he's one of the world experts in not just the upper neck, because there's a lot of people who understand the neck and the cervical spine, but what that relates functionally to your health and what you can do to be healthier. But on top of that, he's trained in neurology, and he's actually doing a few things that are a little unique compared to other practitioners in the world. And so, why don't we take a minute and you can introduce yourself, a little bit about yourself and what you do?
Yeah, sure. So, from a traditional standpoint, I was trained in upper cervical chiropractic. I was trained by the NUCU organization. So, we do like the specialized low force form of chiropractic focused on the cranial cervical junction. Um, Couple years into practice, especially inspired by doctors like Dr. Traster here. I started to do some coursework through the Carrick Institute and got my neurology diplomate. And that set me down the road of really having a passion for taking care of people with vestibular disorders, TBI, and autonomic nervous system disorders. And I would say like one of my big focuses on clinical care right now is just how practitioners, clinicians can improve our messaging for patients and instill a sense of resiliency and what I would call anti-fragility in the patients, because I think one of the places that even some of the best clinicians right now is we fall into traps of and I think this is something that maybe we'll get into later when like the effects of social media, like people get way into the identity of an illness, and once your identity becomes tied to an illness, it becomes very difficult to unlock yourself from that. And I think one of the things that we all could use from, and one of the big core of my messaging now is how do we increase resiliency? How do we increase the ability for a patient to feel independent of needing their doctor, whether their doctor is a functional neurologist or primary care doctor or an upper cervical chiropractor? We want patients to have health independence and not just therapy dependency.
So let's start there because obviously, to be fair, I try to avoid social media, but I didn't grow up with social media. When I look around, I see people on their phone all the time. And when you look at society, society is getting sicker and they're on their phone more, they're on social media more, and they almost have when I was sick for a while, right? I had Lyme disease, I was sick for 10 years, and it was almost like it was really hard for me to find information about anything, right? About health issues, about what was wrong with me, about how I can get better. And today it's the opposite. It's almost there's so much information available. And so, what are you seeing in your practice with your patients relative to first what they're exposing themselves to relative to information, social media, and then how does that come into play with their health that you're seeing?
Well, one of the things that's definitely changed in the past 5 years, I would say, is that many people are actually making a decision to decide to see a doctor based on their social media presence. So before the age of social media, a lot of people would learn about who to see as a doctor, whether from like, personal one-on-one reference points, other doctors referring to other doctors, or they would have to like spend some time just reading, doing some research about the doctor. But a lot of people are making decisions based on like what are the doctor's influencer accounts, what's their presence on social media and things like that. And it just kind of feeds this idea that people are using social media as one of their primary filters for deciding what they're going to do with health information. And that can be a really good thing if the person that they're getting information from is getting really good evidence-informed opinions that isn't overly built up by hype. But there's a lot of people that are just making content for the sake of, getting a lot of likes, getting a lot of followers, and that creates this polarization where people are becoming really ground in into a certain health ideology, or they are getting information about a condition from a patient that is only coming from one patient's perspective. So instead of a world where has been built through, many years of um, evidence, empiricism, we've kind of gone back into this place where like the value of an anecdote and value of a story is becoming disproportionate to what the weight of the evidence is for that person. And in some ways, it's leading people to come see us and give us an opportunity to take care of them where we might not have had that opportunity before. But in other ways, it's having a negative impact on a patient's psychology, on their quality of life, because once they buy into certain messaging about a certain condition, then they see themselves in that condition and they could actually start to manifest different aspects of that condition in itself. There's some really interesting studies about it during the height of COVID, and they called it a TikTok disorder, in which people were following an influencer who had Tourette's syndrome, and they would start to develop these tic disorders based on what this health influencer was actually doing. And so there are all these neurologists all throughout Europe who are getting inundated with all these patients who are developing these tic issues, but they found that they were developing these functional tic issues as opposed to an organic Tourette's syndrome type of appearance. And they started noticing some of these trends happen in other parts, like in Canada as well, but they would actually develop the tick of a different influencer within the Tourette space. And what they found was that there was a social contagion that was being involved here, where when you take a generation of kids, you take them away from being in school and you put them in front of screens and they're just consuming social media all the time, like they're going to seek out reasons for why don't I feel good? Why don't I feel well about myself? And sometimes these people can speak to that, not with any ill intent, but just from the idea that they feel connected to someone that is, coming from across the world over the internet.
Interesting. And are you seeing patients coming in with certain ideologies or certain thoughts about their health that might not reflect their reality, or certain viewpoints that are pretty, I won't say stubborn, but pretty strong to that makes your job harder, or you finally have to re-educate people on what's really going on?
Yeah, I think so. I think we've had some of these discussions in some private chats where like a lot of people think that they have a vagus nerve disorder nowadays, where
Mhm.
people are like finding information about the vagus nerve and they, without a good filter and understanding of what the vagus nerve is and or isn't capable of, they're saying, "Oh, my problem must be the vagus nerve. Therefore, like I must have this problem in my neck because the neck might pinch the vagus nerve and cause these problems." And you and I know that isn't true, and we have to unravel some of these things for people. But when they have that embedded inside of their brain, like I'm going to see this doctor because he knows something about the vagus nerve, so therefore he's going to help fix me because he's going to unpinch my vagus nerve now. Or they're misattributing a lot of their signs and symptoms, like they might have an autonomic nervous system problem, but that autonomic nervous system problem might not have anything to do with the vagus nerve itself. So I think, especially in the dysautonomia space, is something that we're seeing quite a bit of false information presenting itself to patients and patients seeking out treatment because of some of these false informations.
Let's talk about that. What I see is I agree with you. I see a lot of information about people calling up or wanting vagus nerve treatment, where their vagus nerve is overactive or underactive, or it's compressed, or etc. I'm also seeing a lot more people looking for lymphatic massages and kind of lymphatic massages and things of clearing the brain. And those both have some impact or relationship with the neck, right?
Yeah.
So why don't you talk a little bit about the neck in relationship to your lymphatic system and your vagus nerve, and what is true and what isn't true based on what you're seeing?
Yeah, sure. So there's some really interesting things that are happening in the study of upper cervical chiropractic right now. And one of the things that has become really interesting is being pioneered by an upper cervical chiropractor named Scott Rosa. And he's been studying using upright imaging, upright MRI imaging, where he's studying the effects of doing these very low force atlas adjustments and what it looks like in terms of CSF flow dynamics after that. And this has led to and a greater appreciation for something that really kind of just evolved in the past 10 years, which is the study of something called the glymphatic system. So the glymphatic system is basically the way that our cerebrospinal fluid structures can actually go in and clean out the brain of metabolic waste and metabolic byproducts. So there's this cool theory that problems in the glymphatic system can lead up to this backlog of these metabolic toxins that could create neuroinflammation inside the brain, and that might lead to these negative neurodegenerative health outcomes. And all of this is pretty cool in theory, and we know about what some of these things happen inside of mice, but we have no idea what this looks like in humans. But when we make a lot of really aggressive assumptions about the glymphatic system and how the neck might impact the glymphatic systems, like A, we don't actually have empirical data that says that if we work on the neck, that the glymphatic system is going to get better or worse, or even what a perfect, healthy glymphatic system looks like. So that's point number one, is like we actually don't have any idea. It sounds pretty as a theory, but that's still something that would still be in the experimental and theoretical world right now. And
Okay.
the other thing that we're seeing is people will over associate that how much an atlas misalignment, which we're talking about like really tiny amounts of degrees of malposition, can impact the vagus nerve. And certainly there's probably some outlier cases where if you have a really malformed atlas with the bony end that is sticking way too far forward, then sure, maybe some of these cases you might have some physical contact between the atlas vertebrae and the vagus nerve. But the vast majority of these cases, the amount of misalignment that would take to actually physically impact the vagus nerve is extraordinary. Where if you had that much misalignment, then that vagus nerve getting irritated by the atlas is the least of your problems. So people are coming in and thinking that, oh, my vagus nerve must be pinched because my atlas is off. And while I am a strong proponent that affecting the upper cervical spine can impact the autonomic nervous system, I'm definitely not of the mind that getting an atlas misalignment is going to equate with doing actual physical damage or physical harm to the vagus nerve itself. So it does take a lot of unpacking with that, because if you think of someone who has a lot of fear about how they feel because it's attributed to this vagus nerve problem, and they think about like the context of like when I do an upper cervical adjustment with someone, it is very light, it's very gentle, and it could create pretty significant physiological changes in people. Then when people had that idea behind it, then they could think, oh, if it takes just a little bit of force to help improve this problem, it must not take very much force in order to actually cause the problem to begin with, which leads people to being very overly cautious about moving their neck. It leads to people being overprotective about what things might be done to their neck or their body because they're worried that this small disruption of their neck alignment is going to really hurt them. So we have to break some of these um, false ideas before it becomes this really negative health detriment on the person, because they become super hyper vigilant about their problem, and that leads to like this cascade of you know fear and anxiety about the problem. That fear and anxiety leads to autonomic issues, which leads to inflammatory issues, and just this feeling of not feeling well just because they might have this false belief about the problem.
Okay, so let's piggyback on that is when you look at people who might have false beliefs, what is the impact of their health? And then what are you doing in your clinic to try to re-educate them or reframe their viewpoints relative to getting them to feel as good as they can?
For sure. I would say probably the biggest problem is just this underlying feeling of general anxiety when they have some of these false beliefs. So when you have some of these false beliefs, you're going to tend to be hyper vigilant. You're constantly monitoring your body for your symptoms. If you're constantly monitoring your internal body sensations, that's generally not a great place to be, especially if you're suffering with something like chronic pain syndromes, or even some people that have dizziness where they're constantly monitoring their internal body sensation of what their sway feels like that amount of sway or that amount of discomfort might be normal in any circumstance, but if you're hyper vigilant about it, that sway or that abnormal amount of discomfort can become magnified, and the amount of pain and discomfort that you could feel could be exacerbated just from having some of that false belief about the problem. So one of the things that I try to do is straight up during the initial consultation that I have with a patient is I'll ask them, like, all right, so you're coming in with this specific complaint. What do you think is going on from your point of view on how this problem is actually happening? We try to figure out like what is actually going on inside of their own head. So that way we have a safe place to start so we can acknowledge that, yeah, this might have a little bit of truth for it, but here's what we do know about this condition based on the current level of evidence. And this is what I likely think is going on based on my clinical experience and what I've seen other patients who have similar conditions do present with. And when you give them a reframe of how their condition might have occurred, what are all the corresponding factors that contribute to their sensation of that feeling, then we can start to pick and choose different elements of their health that we can improve upon that might help improve their condition. Where if someone is convinced that their neck pain is strictly a biomechanical neck problem, but they ignore the fact that their stress levels can contribute to their neck problem, that their diet and their food intake and their levels of inflammation around the foods that they're eating could be contributing to their neck problem, that some of the factors around the way that they work and their ergonomics and things of that nature could be contributing to that. And when you give patients a menu items or here are all the things that can contribute to how poorly that you are feeling, what are some of the big levers that we feel like that we could pull on for you that you feel like can make your health become better, that you feel like you have better control over it? And I think a lot of the education has to be focused on giving patients a sense of control back to them instead of feeling like something is happening to them and therefore the only thing that could come to save them is another doctor or another practitioner with some special technique that's going to fix it.
So let's talk a little bit about, for people who don't know, can you explain a little bit about placebo versus nocebo
Yeah,
and what
absolutely.
that relates in practice and how you can utilize that as a doctor to try to help people?
Absolutely. So most people are pretty familiar with the placebo effect. So the placebo effect classically is you go to a doctor and they give you a sugar pill, but they tell you that, oh, this is one of the latest treatments that has been developed for this specific condition, but there's nothing about that treatment that is special or unique, but the patient thinks that is something that is special or unique. And because they believe that there's something special and unique about that treatment, they are more likely to experience a positive effect from taking that sugar pill, even though there's nothing about it that would actually make them feel better besides the belief itself. When you have a nocebo, it's when you have a false belief about a condition or a false belief about a treatment that makes you think you're going to be worse than what that condition or that treatment may actually do. So a common nocebo that we see is when patients believe that their pain is exclusively caused by a bulging disc, then they're going to believe that if they got an MRI, they have a bulging disc, all of a sudden their pain actually feels worse than it was before the time that they got their imaging because now they're associating this major problem of a bulging disc actually causing their pain. And then they become really protective about moving their bodies because of this bulging disc. And therefore, because they're being more protected, we're actually becoming hypervigilant and that their pain actually becomes worse because anytime that they think they're doing a movement that harms themselves, their body will actually experience pain from that. You can also have a nocebo from a treatment, right? So we do know that gluten um, intolerance exists, and we do know that gluten sensitivity exists in a very real way with things like celiac disease. And there's people that have different forms of gluten insensitivity. But we also know that there's a large subset of people that are probably been taught that gluten is bad for them, and so they'll start to experience symptoms if they think that they have consumed gluten or they think they've consumed something like even MSG and things like that. And it's not to say that people can't have sensitivity to those things, but a lot of the people that have expressed those sensitivities are might be experiencing a nocebo because of a belief that those things are inherently bad for them, and therefore they will feel stomach aches or headaches or things like that because they think they've been exposed to that. And many studies have shown that a lot of people are experiencing some of those symptoms because of some nocebo type of belief about that. So when it comes to addressing placebos and nocebos in practice, like everything I do in my office is about helping a patient try to get context in a way to maximize the placebo effect in the patient so that they feel that every treatment that we're doing is having a specific purpose for them. We're trying to have a therapeutic relationship with our patients where we are empathetic and kind and very supportive and trying to give them structure that we all know that that type of therapeutic relationship with a healthcare provider actually helps improve outcomes for many patients with pain and some somatic disorders. We're also trying to minimize nocebos. So when we go back to the disc bulge example, when people tell me that they have a bulging disc or herniated disc that they've been diagnosed with in the past on MRI, I'll often bring up this idea that if we were to take an MRI of 100 people in their 40s and 50s that had no back pain and no neck pain at all, 60 to 70% of them would have a bulging disc. Now, this doesn't mean that a bulging disc is completely benign. It just means that people can have a disc bulge and people can have a herniation without any pain at all. And we might not be able to make a bulging disc go away or might be able to make a herniated disc go away, but we could actually do a lot for your body to actually help support your body so that you could have these things in existence and not have any pain at all. So we're trying to break that connection between a belief that if you have this specific condition, that you have to have pain or you have to have a feeling of dysfunction as a result of that.
Amazing. And then you do some advanced imaging on necks, and you've done a lot of it. You see people with different conditions. I think to your point, a lot of people think of the neck as, a mechanical structure that supports their head. And if there's a problem with it, it's probably a disc injury, right? Or a sprain or a strain. And that's about the extent of their health if they're worried about with their neck, right?
For
So I guess
sure.
the first question is there a perfect neck? Is there a perfect curve? Are there things that are goals for you to try to restore certain things about the neck? Is everyone unique? Are you seeing associations with things on imaging versus symptoms? Or when you look at the neck, what are you trying to assess and what are you trying to achieve when you look at imaging of someone's cervical spine?
It's a really good question. So, do I believe there's a perfect neck? I believe that there is probably a maximally efficient biomechanical relationship that can happen in the neck that is probably going to minimize how much soft tissue strain that can happen into the muscles and discs and some of the connective tissue that happen inside of the neck. So I do believe that people can have like a so-called ideal biomechanical relationship, but it's not contingent on having that ideal biomechanical relationship for the patient to actually have a good clinical outcome. So we are always going to strive to achieve the best biomechanical relationship that someone can have for their neck because we believe that if we put people into that as close to that ideal biomechanical relationship as possible, that it is going to help us maximize some of their clinical outcomes. But with that being said, we always tell people like our goal is not necessarily to that you have to be perfect in order to be well. If we are moving you in the direction of having a healthier biomechanical relationship, you're probably going to get better as a result of us moving you in that direction too. And it's the same type of way that we will have conversations with people about, blood pressure or even some other markers like as like glucose or lipids and stuff like that. Like there are pretty well established numbers that guidelines want people to be at. And it doesn't mean that just because your blood pressure is at 125 over 85 that you are going to have a stroke or have a cardiovascular disease just because you're not at below that 120 over 80 mark for that patient. But if you are at 140 over 90, if we are moving you closer towards that 120 over 80, even if we don't hit that goal, it is probably helping to improve your chance of reducing the strain on your cardiovascular system and a lot of the tissues of your heart just as a result of getting you closer towards that goal. And that's how I see biomechanics operating in the same way is we have an idea of what we want to get people to, and we're always going to strive to move people there in a way that is as efficient as possible if it is physically possible for them, but not being able to hit that goal doesn't mean that we didn't do some type of benefit for your clinical outcome or your health overall. It's just about moving you towards that position in the best way that we can with our current tools and technology.
Cool. When you talk about biomechanics in your practice, how much do you weight like a stationary MRI or X-ray or CT versus like a digital motion X-ray versus like a physical exam, watching the person move their neck or feeling the neck muscles versus, sensory awareness of their head and neck. Because obviously different people look at different things.
Yep.
And so what is the value for you of these assessments? Is one more value than the other? Is it a combination of everything? How do you know if someone's neck is causing their health symptoms?
So for me, everything starts with what's the patient's clinical presentation, and that always starts first. So why are they here to see me to begin with? And then once I know why they are here to see me, then we can decide what the best modality and where to put the most weight in terms of our exam is. So if I know someone is showing some signs of something like craniocervical instability, then the static image means a lot less to me than getting someone to DMX because I want to know how much instability there is based on what that patient's primary concern is and what their primary complaint is. If a patient is a primary concern of some type of neck pain issue or some type of um, musculoskeletal problem that probably is driven heavily by some type of relationship between their disc and their vertebrae and things like that, then I'll put a little bit higher weight on some of the static imaging, whether it's MRI, whether that's cone beam CT, or even static X-ray. Then that starts to hold weight when combined with a clinical exam for that patient. And when it comes to the totality of things, I'm always going to kind of look at that clinical presentation and using some of the skills that we developed from a neurological exam that we were taught through Dr. Carrick and the Carrick Institute and things along those lines. And I'm going to use what I find from their history taking and their examination to kind of steer them towards what am I going to put most stock on in terms of what tests and what imaging I think is going to be valuable for that person. So I made a video about this earlier today. We're talking about, vestibular rehabilitation versus upper cervical chiropractic if you have dizziness. So the point of the video was that we shouldn't make decisions about what treatment is better or worse without actually knowing what the condition is going on with that patient. Because dizziness is a super vague thing, and that's one of the things I took away from your course is like dizziness can mean any number of symptomatic complaints for a patient. And if we don't delve into what dizziness actually means for that person, do they mean spinning? Do they mean that they're rocking? Do they mean that they just don't feel right in their head? Do they just mean that they feel motion sick? Until we actually know what some of those things are, then directing the patient towards a specific modality doesn't even actually make sense because the first thing that we got to do is we got to figure out is the person's dizziness because I suspect an inner ear pathology, or did I rule out, or did someone else rule out an inner ear pathology? And now I can start to think about is this a problem that's happening at the level of the neck? And then we can start to do sensory motor testing to actually flesh that out to see, all right, now that we know it's not the inner ear, we've done some sensory motor testing, we have some evidence that suggests that cervical proprioception is a problem. Now I'm starting to feel more confident that if I do some neck imaging and I do a specific adjustment to the neck, that I'm going to have a strong chance of success. Because one of the things I never want to have with a patient is I never want to guide a patient towards treatment if I don't have a high probability of making sure that that patient's going to have a positive health outcome as a result of the treatment that I do with them.
For sure. And let's talk about social media for a minute because maybe it's just me, but I'm being targeted by upper cervical chiropractors all the time. And I see upper cervical accounts all the time with a lot of followers, a lot of comments. And I'm curious from my perspective, are you finding more patients are actually understanding that the neck might have a role in their dizziness or might have a role in their health? And that's why they're searching out more upper cervical chiropractors or more neck treatments? Or is it the other way around? Are we being targeted by upper cervical chiropractors who are now educating people, whether it's good or bad or correct or incorrect, about the neck's role in health? Because the neck does have a role in health. We see a lot of concussions, and a lot of our concussions, a lot of our therapies are geared to improving the way the neck communicates with the brain. Like it's real. And so,
Totally.
so is the question, are people being more educated and looking out for practitioners who understand the neck's role in health? Or is it vice versa? Are people being more nuanced and intelligent of how to get the message across and educating people?
I think we're seeing a little bit of both. I think when it comes to a condition like dizziness, there's a strong sense of desperation for the dizzy patient, I would say. And I think part of that is because, and something that we know kind of intimately, is that modern medicine has not treated the dizzy patient very well. Like, oftentimes, these patients will get a diagnosis, but they're not really left with really good therapy directions in order to try to help them actually feel better. They'll say, like, well, you could try 4 weeks of physical therapy. So they'll get sent to like a box physical therapy studio that may or may not have actual good training on vestibular rehabilitation. And then they don't feel any better after a couple weeks, then they just feel like their condition's kind of hopeless. So I think the combination of a lot of patients with dizziness feeling really vulnerable because they feel like medicine has really let them down as far as the treatment of their disorder has led them to seek out as many avenues for answers as they possibly can. And I think a lot of upper cervical chiropractors have probably seen dizzy patients get better, and sometimes they get better really, really quickly. So it's not uncommon for us where, especially if they have that cervicogenic dizziness, meaning that like they have this history of neck injury or neck trauma. They have some sensitivity to movement. They don't have the actual true vertigo, but they're feeling just like pretty off balance and stuff like that. And then we go in there and we adjust them in a couple of times, and within a couple of weeks, like they're feeling so much better from that. And those are some of our happiest patients that make us testimonials and all this stuff. And if you see it happen enough times, and this was me before I took my neurology training, it's like, oh, dizziness is easy. I could solve dizziness just by adjusting people. But then you start to see like more and more dizzy patients because you develop this subspecialty and you realize, oh man, not as many people are going to respond just to getting adjusted as you originally thought they were, because the more success you have, the more complicated patients that you will actually start to get presented with. And if you don't have the education and training to actually understand why someone might feel dizzy and what all the other tissues and neurological systems that can create this feeling of disequilibrium are, then like you have one tool and everything becomes a nail, or you're a hammer and everything becomes a nail as a result of that, instead of recognizing that, oh, dizziness encompasses this wide spectrum of different conditions, and there's all these different areas that we could intervene upon. And yes, the neck is important in many of those cases, but we also know that it is completely irrelevant in other cases. And we have to have a education about ourselves to recognize that, because, you know, people that are in social media, they're just looking for people to interact with them. They're looking for information to be shared with them, and people and clinicians are trying to show that, hey, I'm really good at treating these types of cases, so I'm going to put that messaging out there, even though that clinician may not actually be the best suited to take care of that specific patient, because they're dizzy and they don't know why. And it's only really like people that are really specifically trained to recognize some of these dizziness disorders that have the ability to tease out why that person might be dizzy if it's not related to the neck or it's some other easily identified cause like benign positional vertigo.
I think if I talk to 99 people or 100 people and I say, how are you going to treat your neck? Maybe 99 would say, get me a massage, right? And I
Yeah.
think massage is probably the most common thing people think about when it comes to neck treatment. So can you explain a little bit why massage is good for the neck, but you do a lot of other things in your clinic that aren't massage? And
Yeah.
so, well, can you first start with massage and say why that could be good, but then describe why you don't massage everyone? And what are you doing with what makes upper cervical chiropractic different? What makes vestibular rehab or eye movement training or different brain therapies or brain-based therapies different? And why have you incorporated other techniques that society might not view or might not understand as a way to get people better?
Yeah. So I have a love-hate relationship with massage because in my experience, massage for the neck when someone is dizzy has not gone well for many of my patients. And I think it's a couple of things. And one of the things I took away from your course when we're taking the vestibular rehab modules is like you could have a vestibulopathy where they lose function of the inner ear. And the brain is always going to try to compensate in some way. And sometimes they're going to compensate by making your muscles of your neck really tight. And when your muscles of your neck feel really tight, you feel stiff and you're achy. And what do you want to do when you have these tight muscles on your neck? What typically feels good when you have tight muscles in your neck is you're going to start to rub them. And when you rub them, yeah, sometimes those muscles will loosen up. But what if that was your brain's best way of compensating for this lack of input that's coming from the vestibular nerve? So you just took that patient that had these tight neck muscles that's trying to restrict movement of the neck, and you took away one of its primary compensations. So what ends up happening, and what I've seen in many cases, is a patient will get a massage and they'll actually feel pretty poorly from a vestibular standpoint after they've gotten a massage. And a lot of patients didn't necessarily put one and two together, so they didn't recognize that the massage might have decompensated them. They just think that they experience another flare up of their vestibular problem that just coincided with the massage happening at that point in time. So I think massage is great, but depending on your vestibular condition, it might not be the best course of treatment for addressing it. And even some of the high velocity, low amplitude spinal manipulation techniques might not be great for some of those patients too, because of the same reasons. Like you're decompensating that patient who might have that neck stiffness as a compensation for that vestibular loss. So from my perspective, I like using some of these low force upper cervical techniques, and some of the upper cervical world would probably not love my thoughts on this, but I don't think that we are doing the same thing with a low force upper cervical technique as doing like a high velocity, low amplitude manipulation to the neck. I think the reasons for why a patient may respond to that are probably more through the way that a low force upper cervical technique is going to interact with the sensory system, specifically through some of the skin and some of the deep cervical musculature. And we're probably creating these very subtle proprioceptive changes inside of the neck. And one of the things that I always kind of have a radar for is making sure that the treatments that we do don't overstimulate a patient who has a vestibulopathy, because a lot of patients with vestibulopathy, they tend to have hypersensitivity of one or more sensory systems. So their hypersensitivity can often manifest with their visual system, but some people might have hypersensitivity through other parts of the nervous system too. So I think these low force upper cervical techniques are able to provide a useful stimulation for the patient without crossing the threshold of overstimulating them and making them feel like crap afterwards. So I like having this big toolbox of using some of the vestibular rehab techniques, some of these oculomotor therapy exercises, because it allows us to do this very slow, guided, stepwise way of stimulating the brain in a way where the brain can take the information and make it useful, as opposed to being hammered by a lot of stimulation all at once and likely making that person's nervous system kind of crash out and feel pretty poorly as a result of that. So that might mean doing a low force upper cervical realignment, or it might just mean doing some very slow VORs. It might mean sticking a laser on their head and just following a moving target for a little bit. So we're just trying to progressively load the nervous system in a way that they could tolerate, in a way that encourages them to do more and more work over time. And I think the ability for a patient to do more and more work over time is probably going to lead to the biggest wins, as opposed to trying to fix something all at once in one or two treatments.
Okay, and to add on to that, I think again, most people, if you think about the neck, they're going to think about the muscles and maybe the spine. So why don't you explain how in the world does the neck relate to the brain? And how you view the neck maybe differently than someone who's just looking at it as a bunch of bones with muscles that move it.
For sure. So when people have a just strictly musculoskeletal framework of the neck, then they're going to try to identify where has the neck been injured, which it comes down to muscles, the joints, the discs, some of the nerves, maybe even some of the blood vessels if you're kind of going into that level. And when you look at it from that standpoint, you're either just trying to identify, is there a point of nociception or is there not a point of nociception? And if there's not a no point of nociception, then there's nothing that you could do to actually that's worth treating the neck for. But some of the perspective that I gain from taking different coursework is that if we see the neck as being this sensory organ almost in the same way that we see the vestibular nerve as a vestibular system as a sensory organ, then it opens up a whole wide arena of different ways you can interact with the neck to provide therapeutic value for the brain. Because the way that the neck and some of the proprioceptors from the neck interact with the brain is pretty unique in terms of the spine compared to the rest of the spine as a whole, because of the way that the neck interacts with parts of the central vestibular system, because of the way that the neck can have pretty strong interactions with the autonomic nervous system. I think it's quite unique in that standpoint because you don't get those same similar types of relationships coming from the lumbar spine or the pelvis or other structures like that. So when we could see it from that standpoint, and we're just trying to enhance the way that the neck is used as a sensory perception organ, then it allows us to do things like joint position error types of therapy. It allows us to use like these head laser exercises as a way for the brain to have another source of feedback. And if we're using the neck as a feedback mechanism, then you don't necessarily have to have pathology in the neck to make the neck something that is useful to help the brain try to figure out where it is in space. And if the end goal for so many of us that work in this space is to help the brain get a better understanding of where the head is located, then it just makes a lot of intuitive sense to use the neck as just one of those avenues to help increase the fidelity of how the brain is interacting with the world around it.
Perfect. And I think when people think about neck problems, I think inherently they think neck pain, right? Stiffness and pain. In your practice, when someone has an issue with their neck, or when you treat the neck, what type of other symptoms are you seeing? Or what other symptoms are you correlating with? Okay, if they have this symptom, it could be their neck. Or when I treat their neck, these are all the symptoms that I could expect to get better besides stiffness and pain.
Sure. Headaches are a big one. So both tension headaches and even headaches on the migraine spectrum are things that we tend to see happen pretty coincidentally with neck problems. So especially if we were like palpating some of the fibers in the upper cervical spine, that you can almost recreate someone's headache or migraine patterns. That is almost like a guaranteed home run case for us. Just because we know that like, hey, we found this spot where we're irritating this joint and we just irritate it a little bit more, it reproduces it, then that's usually a patient that is going to respond really well to a lot of cervical-based therapies. Cervicogenic dizziness, so any type of equilibrium issue that wasn't already associated with positional vertigo or other vestibulopathy. We even found some cases of autonomic symptoms related to POTS to be pretty receptive towards getting treated with this. That one's a little bit harder to flesh out in terms of like finding who's going to be a good candidate that's going to respond to this versus those other two conditions. But I would say that's one of the things that we've been seeing quite a bit of lately. And then you have some of the pain that is going into the middle back, the upper back area, into the shoulders, partly into the arms. I think those are areas where people will still don't have a strong recognition that like, hey, if I have some arm pain, that this could be a lower cervical problem, or if I have a pain that goes into the upper back, that could be a lower cervical problem too. But many times we'll see that like oftentimes we could just treat that area of the spine and we could actually get pretty good outcomes and results with that as well. So I would say those are the ones that like we see very, very frequently respond quite well to cervical therapies.
Cool. So you're a big proponent of anti-fragility, right? I see you posting on yourself when you exercise. I see you talking about patients with it. So why don't you explain a little bit what is anti-fragility and why does it mean so much to you?
Yeah, so like one of the things that I took away of like being into sports and like doing things that kind of like force us to enhance our mental toughness is that when we are exposed to controlled amounts of adversity, like people actually become better, stronger, tougher people as a result of it, because it comes with the understanding that like the world around us isn't always going to work out in our favor. It isn't always kind to us. But a lot of people think that the solution to address that is to try to make the world around you softer so that people can exist in it better. But I don't think that's a sustainable solution because it creates this incentive for people to continually try to make everything around the world easier to do when the most obvious solution is if you want to make someone tougher and more resilient and more likely to succeed in a tough environment, then you have to do things to them to challenge their system and reward getting through tough challenges. And from a patient care standpoint, one of the things that we really try to emphasize in people is that injuries can happen to all of us, and we could do things to like bulletproof our back, we could bulletproof our knees, bulletproof our shoulders. But the reality is, injuries are coming for us no matter what we try to do to try to prepare a lot of our tissues. The best thing that we could do is to expose ourselves to these stressors. And by exposing ourselves to these stressors and taking that small risk of injury, we are going to enhance our ability to overcome an obstacle whenever it presents itself. Because a lot of us, I think, we do too much to try to protect patients from the world around them. And that means, let's see, if we take it back a little bit, a lot of this moniker actually came from a frustration of mine because there's another upper cervical chiropractor that became well known to like put a neck brace on their patients after that they adjusted the person. And in my point of view, this was inducing a nocebo into that patient because now that they think that if I do something small, without my neck brace on, I'm going to become injured. I'm going to need more adjustments again. I'm going to mess myself up. So I created this to actually push back against that idea is that instead of trying to hyper protect yourself from losing your adjustment, let's do things to actually challenge your brain's ability and your body's ability to recover from different movements. So I want the patient to lift weights because when we lift weights, we are creating these small little tears inside of our muscle tissue. We're creating these small little strains inside of our tendons. But when we recover from that exercise, we recover from that training, your muscles and tendons actually get stronger as a result of that. Whenever we push ourselves from a cardiovascular standpoint, we are putting our heart under a little bit of strain. But the net benefit is when we recover from that, our heart actually becomes more elastic and actually a little bit stronger as a result of doing that. And when we are weightlifting, we are putting some stress on our bones, but the net result of putting that stress on our bones is that our bones are going to become stronger 5 to 10 years down the line. So the goal of anti-fragility is that we have the ability to expose ourselves towards the things that we are afraid of. And by exposing ourselves to it, we are actually preparing our brains and our bodies to become stronger because we are confronting our stresses instead of running away from them. And I think when we teach people from that framework, it creates a patient that is going to be mentally stronger and tougher when they are going through a process of an injury or recovering from an illness. And I'll use my own injury as an example. Like I tore my Achilles a year ago. And when people tear an Achilles, like especially in their 40s, it's very easy to say like, oh, I should give up on physical activity because it's too much for me and all this other stuff. But if you take the opposite mindset, you could actually start to recover and rehab from that Achilles tear a lot faster by saying, you know what, I tore my Achilles, but I'm going to start to slowly expose myself to the stress that made my Achilles a little bit of a weak point to begin with. And from that, I feel like I recover from my Achilles injury faster, where I'm at a point where like I'm running 4 to 6 miles again, a year out from my injury. So I think it's just one of those things where it's healthy to have a mindset where we could train our bodies to feel like it is strong and is resilient, and that even when it gets broken, that we could do things to recover and bounce back from it instead of falling victim to the throes of an injury ruining our life. We could take it as an opportunity to make other things stronger and become a stronger person as a result of it.
And you make a good point. To finish up, a lot of people and a lot of patients are afraid, right? They go, they stand up, they get dizzy, they get tired. They move their head, they feel worse, right? And a lot of people don't know where to start or how to start doing things, and they're afraid of their symptoms, they're afraid of hurting themselves. And then you add a good point where if people haven't been to an upper cervical chiropractor, it's very minimal,
Yeah.
right? And if it's that minimal, whether it creates a great response or a negative response, if that little stimulation could do so much, then what about turning my head, right? We know
Yeah.
just rotating your head can reduce your blood flow by 50% on one side, but you're fine, right? There's a lot of collaterals and a lot of ways you could deal with it. So how do you balance out people who are inherently afraid to do therapies and to do things with the fact that what you do is pretty subtle and try to teach them the impact? Yes, this is subtle, but we need you to move your head. Or yes, this is subtle, but it doesn't mean that you need to be in a neck brace, right? Because, oh, yeah, I'm not turning your head and cracking it. But just because I did a subtle therapy doesn't mean if you turn your head or move around, it's going to fall apart or my therapy was insignificant, if that makes sense.
Yeah, totally. So it's definitely one of the more challenging conversations that we do have because that is one of the beliefs that people have, especially when they experience a really good result. And I would say that one of the ways that we do make a point is like we find the movements that our patients are reluctant to do or afraid to do pretty much from the day of their exam. And we let them know it's like, hey, currently we know that you have a really hard time turning your head to the right now. You seem a little bit apprehensive, you seem a little bit fearful of it. And I want to let you know that one of our goals is that you're going to be able to turn your head better without it causing your symptoms. But in order for us to help you achieve that goal, there's going to be a point during our treatment that we are going to challenge you to move your head slowly and then faster and faster into the direction that you're a little bit afraid of. And that's okay. I'm going to be here to guide you the entire way. And I'm never going to put you into a position where you're going to feel a lot worse than when you were when you came in. But we're going to try to find that balance where we're going to challenge your nervous system to start to do this activity so it's no longer afraid of doing that activity anymore. Because one of the best things that we could do is that we can make it so that your success is independent of me treating you every single time that you're coming here. My end goal is that you are able to walk away from here, that you could do your own exercises, and you're going to be able to manage 80, 90% of your own condition just from doing some of the therapies that we're going to do with you and by doing them with yourself at home. And it takes some work to do that. It means that we have to open up a window of opportunity for the patient to be able to do some of these things that they're afraid of and not have their symptoms flare up as a result of that. And I think that's part of our job as functional neurologists is we want to give patients a pathway where they could do something that they were initially felt debilitated by that movement, but we gave them some type of sensory activation or some type of pathway where they're able to accomplish that movement without their symptoms flaring. And when we're able to open up that window of opportunity, I think we not only help the patient believe that they could do it again, but we also get that patient's brain to believe that they could do it again, which I think counts for a lot.
Amazing. And let's finish up if you're open to it a little differently, because obviously we're all specialized in certain things, but sometimes people have different disorders that aren't in our wheelhouse, right? You've been a big advocate on autoimmune conditions, and different, whether it's lupus or other things. Um, could you discuss a little bit about what you've learned over the last few years about autoimmune conditions and kind of your experience of sometimes it's not your treatment that's going to help someone, sometimes it's finding the right person that does something different.
Yeah, totally. So, yeah, my background with autoimmune disease obviously is not one that I would wish on anyone, but my wife ended up having a catastrophic form of lupus called catastrophic antiphospholipid syndrome, which caused multiple strokes, multiple clots to happen inside of her body. Fortunately, like we were able to catch it in time where we were able to get hospitalized treatment for her. And we ended up getting into a rheumatologist and using just the knowledge that we've gained from just being a good healthcare provider, we were able to find her a treatment that was really able to help her recover from this illness. And she's doing really well in spite of having this condition affect her 5 years ago. And I think certainly as a result of watching my wife go through and suffer so immensely from having an autoimmune disease, it's definitely made autoimmune disease much higher on my radar whenever I'm interacting with patients. And it makes me want to help them identify the fact that they might have a brewing autoimmune disease underneath the surface so that maybe we could help them get appropriate treatment faster than a lot of people because there's evidence that suggests that many patients with things like lupus or other autoimmune diseases may suffer for 7 to 10 years before they actually finally hit their diagnosis and start to get appropriate treatment for that illness. So I always want to make sure that I play an important role in being able to help some of these patients who are suffering from a lot of these vague symptoms, but they have elements of that autoimmune type of concomitant to it, that we could use that as an opportunity to maybe go get them a blood test or get them a consultation with a rheumatologist before their disease becomes really, really bad.
And then,
So
and
I'm,
then some people like, because obviously a stiff neck can be associated with a lot of things. Pain can be associated with a lot of things. And like you said, early recognition could save someone's life, right? Not just
yes,
with autoimmune conditions, but for a lot of conditions, right? And as a chiropractor, obviously people talk about vascular health and things like
yep.
that, which is rare, but it's a real thing. But so what are you looking for, or what things pretty much saved you guys that you identified earlier that really helped you say, wait a second, let's go see someone else because I don't like the look at this.
Yeah, so a couple things for us is like when I was looking at my wife during some of the later stages where she was feeling really, really poor, she actually started to show some nystagmus in her eyes. So I would open her eyes at nighttime. She would show a little bit of nystagmus there. She was showing neglect when they was having her touch different parts of her body. So like all some of the symptoms are like, ooh, this strongly looks vascular here. So just seeing that, like, all right, I just gotta go get this ruled out before this confirms my my thoughts that this could be really, really bad. So that was my ticket to say like, hey, this might be a stroke here. So I took her to the ER at like 1 o'clock in the morning. I woke her up and took her to the ER just as a result of seeing that some of that stuff present itself there, which yeah, I don't think I might have made that decision if I didn't have some of the background in neurology that I did. And for other autoimmune diseases, I'm looking for like a lot of the morning pain. So when people have like really bad pain in the morning and it kind of gets better throughout the day, when people have like random flare-ups of the condition where it's not doesn't seem like it's specifically triggered by specific things. And obviously I'm looking for, the redness and tenderness in your joints and things along those lines to kind of point me towards the idea that hey, this might be some type of autoimmune issue as opposed to like a standard musculoskeletal type complaint.
And if you can you educate people a little bit on lupus? 'Cause I think some people might just think it's some red cheeks, right? Can you educate people, A, what is lupus? And then B, whether it's kidneys or other organs in your body, what can go bad and why is it so important to recognize this and see the right doctor?
For sure. So lupus is a systemic autoimmune disease, or systemic lupus is a systemic autoimmune disease where your body is producing antibodies, and those antibodies will inadvertently attack the body's own cells. And it can manifest in many different ways. A lot of people think about lupus, they'll have like the butterfly rash on their cheeks where they'll show like a pink, reddish butterfly shape that goes across the cheek. Which when people think of that, they think like, oh, it's this could be like this skin disorder. But the reality is lupus has a lot of devastating internal organ consequences to it. The most common is kidney disease. So lupus is known to attack the kidneys and it could cause a progressive or sudden destruction of kidney tissues called lupus nephritis. And that's one of the manifestations that my wife ended up having that we had to get treated pretty quickly before she would lose too many kidney cells that could put her into kidney failure, because that's one of the pathways for lupus is many patients can develop kidney failure because you'll actually feel your kidneys losing cells. It just can start to happen over time, and if you're not monitoring that closely, you might not notice that you're having protein leak into your urine and things like that. Lupus is highly known to affect the cardiovascular system, so it's shown that a lot of patients with lupus develop cardiovascular disease early. Um, and it could cause clotting conditions, which was the specific phenomenon that happened for us is it caused widespread thrombosis that affected their kidneys and heart. But there's also neuropsychiatric consequences. A lot of people with lupus can develop pretty profound cognitive symptoms. It could also develop skin disorders too. And some people, and this is where we didn't recognize it in time, but when my wife was pregnant, her first sign was she developed an anemia, and you didn't necessarily feel anemia or anything like that, but on some of her routine testing, her hemoglobin was down to like 10 or 11. And we didn't think it was lupus at the time, so it was just treated as some type of autoimmune manifestation of pregnancy. So she was on steroids for that time, but then when she had the baby, we stopped taking the steroids, and then lupus ended up developing fully after that fact. So lupus, like there's that old show is a House MD where the common phrase was like it's never lupus because like the doctors were always having like a patient with this cluster of random symptoms. And one of the first things that they always say is like, well, maybe it's lupus. And then House would say it's never lupus. But lupus is one of those conditions where like it could affect so many body systems that you never really truly know like if that condition is related to lupus or not unless you actually get the blood work done and really test to rule it out.
Awesome. Well, I really appreciate you opening up about that because I think it's important, although our talk is about the neck and the brain, that people could have more than one thing.
Yeah,
And people could have things that are more serious. Not that what we do isn't serious and helpful, but there are things that are much more time sensitive and there are things that can kill you,
yeah,
right? And although people might feel like death lying in bed every day, there's a lot of people with dysautonomia who are relatively healthy in the big picture. They're just not very functional. When there's other people, you've really got to identify things and you could save their life, whether you're a chiropractor, physical therapist, and medical doctor. acupuncturist, athletic coach, or just your sister or brother, right?
Yeah.
Identifying these things are really a big deal because people are getting less healthy every day in our society, and we're seeing more and more frank pathology that just gets missed by everyone for years, and it's devastating. And I'm
Yeah.
glad you're doing better. Obviously, your wife's doing better, and obviously it affects your whole family. Your kids are well. And I really appreciate you taking your time and spending the time educating everybody on everything you do. So I appreciate it.
Thank you.